decrease in the numbers, which is good. And I think all citizens of Trinidad and Tobago, because this is your, I don't want to use the word victory, but this is your accomplishment. Because we could not have achieved this downturn in numbers, which we hope will develop into a permanent trend, without members of the public in both islands wearing their masks, social distancing, washing their hands, staying home if you are ill. So we have some reasonably encouraging numbers to talk about this morning. What is happening globally? The pandemic shows no signs of a global slowdown. There are 34,788,605 cases globally. The daily average of 300,000 cases per day has remained constant since August 19th to September the 30th. So these numbers I am giving you are up to September the 30th. The number of deaths has regrettably crossed the millionth mark. It is now 1,032,163. And the daily death toll from August 9 to September 30th, which is the figures I am giving, still hovers above 5,000 a day with no signs of decreasing. Our deepest condolences go out to the 78 persons in Trinidad and Tobago who have succumbed, and our deepest condolences again go out to them. But we are starting to see some positive signs, and we want this to continue as we report to you these figures, not only on a daily basis, but what you will start to see from today is a sort of a weekly review. So this drop in cases is to be congratulated to all members of the public who worked with us. I just want to close off briefly with where we are with the flu vaccination drive, because what we are trying to do, the global community is now adopting this word of a twindemic. We are trying to avoid a twindemic in both deaths due to COVID and seasonal influenza. So the annual flu shot drive is annual, it's every year. Whether you had a shot last year or earlier this year, you still need a new one. We distributed into the system 22,000 doses. So far, up to the latest figures I have, we have given out 3,934 doses. Our target per week is 10,000 doses per week for the first 6 weeks. And we are especially encouraging the following 3 categories of persons to get vaccinated. 1, our healthcare workers. 2, our elderly, especially those of you with diabetes, hypertension, the sedentary ones, persons with cancer, and what we call the comorbidities. And lastly, very importantly, our pregnant women. Please get vaccinated. We want to get up to about 10,000 doses per week. And the last figure I have is 3,934. So we need to double 2.5 times that. It's free. It's available at a range of health centers that is on our website. We have also published it. So make use of this free flu vaccine so we could avoid what is being called a twindemic. Thank you very much, Candice.
Thank you very much, Minister Dayal Singh. Dr. Avery Hines will now present the clinical and the epidemiological update.
Good morning, and thank you, Ms. Alcantara. Good morning to the Minister of Health. Good morning to the members of the viewing and the listening public. The update for October the 3rd is as follows. To date, the number of samples submitted for testing has reached 32,122. Of those, 29,017 are unique tests completed for individual patients. The number of repeated tests stands at 3,105, and the number of samples testing positive stands at 4,709. There are currently 1,829 cases considered active in the various part of the healthcare system, whether it is home isolation or at hospitalized at institutions. There have been 78 deaths, and again, we extend our condolences to the bereaved family members. Number of persons discharged from the public health facilities stands at 1,086, and the number of recovered community cases is 1,716. Of the 80 additional persons who would have tested positive between the last update and today, those individuals will now be processed for admission at the clinical discretion of the CMOH under whom they fall. We do have a breakdown of the individuals who are currently institutionalized. The institutionalized individuals are in two settings. One is the hospital setting, where we have 103 patients spread across the Couva, Cora, Rima, St. Anne, Scarborough facilities. And we have 13 individuals in the transition or step-down facilities spread across UEDB and in Tobago. Of the 2 additional deaths which we would have announced today, subsequent to the last update, one individual was an elderly male and another was an elderly female with what we refer to as pre-existing conditions, pre-existing chronic disease conditions, and that brings the total to 78, as the Minister would have alluded to. That, in brief summary, brings me to the end of the clinical update. We would now like to move on to the epidemiologic update, where there are a few slides that we would like to present. So next slide, please. As usual, we have our epidemic curve showing the samples by date of collection. We will circle back to discuss this in a little more detail, but let's move to the next slide. What we do see on the epidemic curve is the continuing trend in a downward direction when we look at the number of samples testing positive, grouped by the date on which the samples were collected. So the black line that we do see moving across the colored bars is what we call a trend line. It looks at the average number of cases over a pre-existing period, approximately of 7 days, and we do see that that downward trend continues, and we're hoping that the behaviors that we have been encouraging will be continued so that the downward trend in numbers of infection can follow suit. Next slide. We have an additional slide, and this just shows the total numbers of cases that would have been reported, aggregated on a weekly basis. And the important bit of this is showing the same trend line and the same shape of the trend, where we would initially have risen to a peak, and at the last couple of weeks, because this is a week-by-week graph, we have seen a week-on-week decrease of approximately 35% between a week before last and now, and last week and this week. So we're hoping that that trend continues. Next slide. We now have the demographics looking at age and sex distribution. Next slide. And the age and sex distribution basically stand as we have previously seen, with the majority of the cases in that 25 to 49 year age group. One thing I'd like to point out on this is the relative quote-unquote sparing of the younger age groups, where we see that the pyramid is constricted, it's narrower at the bottom, there's smaller numbers at the bottom, and that constriction actually does indicate that some of the activities, the actions that we have taken to protect school children and school-aged children by sequestering them have had the desired effect of reducing rates in those age groups. Next slide. The slide on the fatalities emphasizes what we've always emphasized, which is that the majority of those who have passed on have been males, have been in the older age groups, 60 and above, carrying the majority of those deaths, and the under 50 age group really carrying only about 13.2% of the deaths. But we do want to emphasize that that does not mean that persons under 50 should not be concerned about clinical outcomes, and we want to encourage everyone who has respiratory symptoms, especially if you're diagnosed with COVID-19, to take your symptoms seriously and to take any worsening of symptoms seriously so that you can be appropriately dealt with by the health system. Next slide. The geographic distribution is as follows. Next slide. We do see the established pattern of clustering throughout the population centers, East-West Corridor, Rima, Sangre Grande, San Fernando. We also see the additional distribution of cases in the more rural areas, in the eastern areas, which initially was not a feature of the geographic distribution. So we want to emphasize that everyone across the country needs to continue to take the precautionary measures to reduce the risk of spread. And to look at it a slightly different way, next slide. If we look at the distribution in sort of a heat map, this map shows even geographic areas. So not communities as the previous one we showed, but basically a certain square kilometerage and a number of cases in that geographic area, with the dark blue being the darkest blue being no cases, the dark blue being the smallest number of cases, and as you go from blue to red, you see that you have more cases per unit area. This distribution shows that, again, we have the greatest number of cases, the greatest concentration in the urban areas, but we're seeing increasing distributions in that rural setting, along country roads. So we do want to, again, encourage all individuals to maintain hold the fort, maintain the behaviors that will prevent the spread of COVID-19. I'd like us to go back to the slide with the epidemic curve. And I'd like to go back to that for one simple reason. So if we can pull the epi curve back up, that was slide number 3, I believe. The thing that we want to point out about the epi curve is that there seems to be a little the slide before that one. There seems to be a little misunderstanding about the use of some of the tools at our disposal. So we just want to take the opportunity to point out that while this tool is the best for showing the temporal distribution of cases, this is not the tool that we use to quantify the total number of cases that we have. As public health practitioners, we sit at the nexus of data analytics and clinical practice and public health practice, and we utilize a wide range of tools that are at our disposal. The EpiCurve gives us a better idea of when cases may have showed up in the health system in a temporal fashion, and this curve shows a shape, a pattern that allows us to understand when we would have had the highest levels of activity and when those levels of activity would have begun to decline. Again, the numbers, the absolute numbers represented on this curve, because this was actually generated from a separate data source using corroborating information. That separate data source would allow us to see whether the trends that we would have been observing in numbers of cases being confirmed positive on a daily basis correspond with what's happening in the general population, and that is the purpose of utilizing this day-by-day breakdown. But the utilization of that to quantify, or the approach of looking at the numbers as being different from the total numbers of cases that have been reported, is basically a misunderstanding of how we utilize the tools at our disposal. As a clinician we would use thermometers for temperature, we'd use our blood pressure machines to check blood pressure, we'd do blood tests to see what's going on with your blood count, white cells, red cells, etc. In a similar fashion, we utilize different tools for different purposes to get an idea of the overall story and an idea of the trend in the evolution of the epidemic. So I'm hoping that that's a little clearer. We'll be happy to clarify further during the question and answer section.
Thank you very much, Dr. Hines. And we move to the question and answer segment. Members of the media, you're reminded, please to brief questions and to state your name and the name of the media house that you represent. We begin this morning with questions from TV6, please.
Hi, good morning, everyone. Dr. Avery Hines, can the apex of the trend line in the epicurve be attributed to any public event? And can months and dates be attached to the trend line to give some clarity to behavior and movement over the months, so that, going forward, we will know what to do when another, or if another pandemic ever comes around next 5 years?
Okay, thank you for the question. I'm interested in your timing of the pandemic in a 5-year time frame. We have no idea when pandemics will or will not occur or arise. Nonetheless, as we have repeatedly described, the epi curve shows a relationship between behaviors and outcomes. We have described this relationship ad nauseum in the various press conferences, expressing concern about the levels of movement that would have occurred after restrictions had been put in place, after advice had been issued to reduce numbers of gatherings, to manage the social distancing, and after observing that none of those behaviors had been adhered to, especially in the first part of August. After that, what we saw in the epi curve is basically what was expected, what was predicted, and what was projected when we explained that we will see an increase in the numbers of cases as a result of behaviors that were demonstrated. A good thing about the epi curve, looking at the temporal distribution of cases, is that you're quite right. We can see when behaviors have the desired impact and when we're not having the desired impact, and we need to encourage individuals to continue to follow the guidelines, the rules. And as you again rightly pointed out, in knowing what to do if we have another respiratory epidemic at any point in time, the adherence to the basic and simple instructions to reduce gatherings, to increase spacing, to cover faces, mouth and nose, that is, with a mask of a particular sort, whether it is a double or triple layer cloth mask or a surgical mask. All of those instructions will, if followed, lead to the improved outcomes that we're hoping for. So I'm glad that you've actually tied the shape of the epi curve to the behaviors, because it is one of the things that we utilize to see the relationships between behaviors and the clinical outcomes. So that was a very good question. Thank you.
Thank you very much, Dr. Hines. And we move now to Power 102.
Good morning, Head Table. Kimberly D'Souza from Power 102 and Israel Media. Minister, I have just one question for you. I realized that the repeated tests have increased. I think we were at 3063 for a while, and we're now at 3105. I just wanted to know if there's an update on the number of test kits we have in the country in terms of the BGI and the Abbots and that sort of thing. Thanks.
So I have that for you, so let me get that to you now. Right, so we have 3 types of test kits in the country: BGI, Abbott, and test kits for the Gene Expert machines. Okay, so for BGI, we have 20,200 in stock now, and we have an incoming shipment from PAHO of 10,000, but then we also have a rolling order like every month for about 20,000. For the Abbott system, we currently have 1,920, and in the first week of October, which is now, between now and early next week, we have 36,384 tests coming in. And again, we have a rolling order now for about 20,000. The Gene Experts, which we use very sparingly, these are not used for large numbers. They are used mainly in Tobago and Sangre Grande, and some at the TPHL lab in Sinclair there. We have 780 in stock. So currently, we have 22,900 tests in stock across the 3 platforms. And as I said, we have rolling orders now every month for between 20 to 40,000 test kits. Thank you for your question.
Thank you very much, Minister. Ms. D'Souza, did you have a second question? Okay, seems not. And so we go to TTT, please.
No, I don't.
Yes, hi, good morning. Now, 35%, sorry, Sonal Lala from TDT News. 35% decrease in cases is quite a significant decrease. Minister, do you foresee the Prime Minister, I know he's supposed to hold a press conference again on October 10th, I believe. Do you believe this would influence his decision-making going forward? And my second question, I've gotten a question from someone. They want some clarification on non-contact sports. They're asking, does it mean that one-on-one swimming and gymnastic classes are allowed, where there's only one instructor and one child with no physical contact in a private pool?
Okay, so thank you for your question. So the Honorable Prime Minister will make those determinations as to what is opened up or not opened up, as the case may be, next week. I will not preempt his decision. What I will say, his decision making so far has been absolutely spot on. But what we will look at, and as public health persons will tell you, the more you open up and the more people move, we need to have even more compliance with the public health measures if we are to open up more and more. So we await the Honorable Prime Minister's decision. On the issue of sports, all contact sports like cricket, football, team sports are not allowed at this point in time. Public pools are closed off, so if someone has a private pool, they are allowed to be in their private pool. So if one person wants to swim in their private pool, as far as I am aware, that is allowed under the regulations. Thank you very much.
Thank you, Minister. And now we are ready to take questions from AZP News, please.
Hi, good morning. Priya Bihari, azpnews.com. Minister, I'm not sure if this you can answer this question, but I have to ask it. A number of employees who have to stay home because of contact tracing or because one of their colleagues in their workplace are contracted the COVID-19. Some of them, when they go home, they are not being paid and they are having difficulties with their employers in terms of accessing salary and accessing the NIS benefits that they are allowed. So they just wanted to know if that issue can be taken up. Is an issue we have had a number of complaints from various organizations. One, and the second question, I just wanted you to elaborate a little bit on the 35% decrease in cases. What exactly does it mean? Does it mean since March to now we have had a decrease? Can you just explain exactly what that decrease is about?
So Dr. Hines will take the second question. As far as your first question is concerned, this is an issue that I would not have information on, but I will surely pass it on to the relevant authorities. Dr. Hines.
Okay, thank you for your question, Mr. Bihari. The 35% decrease that we were speaking about really referred to the graph that showed the cumulative numbers of cases on a weekly basis, comparing 1 week with the week just before it. And we were looking at the comparison between this week and last week, and the comparison between last week and the week before. And we saw that from the week before to last week, we saw a 35% decrease, and this week seemed set to end on a similar trend of another 35% decrease between last week and this one. So the 35% is really a week to week that we're speaking about at this point in time.
Okay, thank you very much. And we're ready now for Newsday. Please pose your questions.
Hi, good morning. Janelle Souza from Newsday. The Council of Evangelical Churches has asked that the government recognize the importance of religious organizations, especially as the government noted that their importance when it came to the distribution of hampers and so forth. Do you have any response to that? And with the 35% decrease, do you think this could possibly be changed soon?
Thank you. Yes, so places of religion are very important, and religion is very important. The Honorable Prime Minister will make determinations next week as to what parts of the economy or the system that will be opened up. I will not preempt the decisions that the Honorable Prime Minister will make, but let me say he has guided this country brilliantly in making the decisions that have to be made to save lives and livelihood. That is what we are about. Thank you very much.
Thank you very much. And now CNC3, we are ready for your questions, please.
Hi, good morning. This is Srini Gray from CNC3. I wanted to ask a question about the length of time it takes a person to be tested currently under the system. Just an update on that. And yeah, that's about it.
Okay, thank you very much. So I will take that question. The testing procedure goes like this. 1, you have to do a patient assessment and you have to do swabbing. Take some time. 2, the sample has to be transported to a testing site, whether it's at CARFA, TPHL, the North Central Regional Health Authority, or Southwest. You have to issue a receipt. The sample receipt has to be validated, it has to be registered, and then it has to be triaged. In other words, level of importance. Then you do the actual testing, validation, and reporting. Then you have to publish those reports, and then the patient has to be notified. So right now, it's a 6-step stage. All in all, this takes us between 24 to 48 hours, depending on volumes and so on. Outside of this, we also have the Gene Expert machines, where you get your test results in a matter of hours. So there are 2 systems. The immediate results, low volume Gene Expert machines, you get your results literally in 2 to 3 hours. And then for the other machines, the other PCR machines, which are scattered throughout the country, it can take up to 24 to 48 hours, which is the ideal in keeping with international norms at this point in time. And I'm happy to report that we are now sticking to those times after we did have that spike in August, September, where admittedly, and I apologize to the country for that, we were overwhelmed at that point in time. But if we continue at this trajectory, we will have absolutely no problems. Our current testing capacity is 1,277 per day, but that is running flat out, and you can't run any system flat out 7 days a week. Systems will break down, people will break down, and you will bring errors into the system. I can tell you now, and I'm being upfront, one of our machines has to come off line for scheduled maintenance. So the machines need to be maintained. Sometimes software needs to be upgraded. So we have a capacity of 1,277, but it doesn't mean we can run this system 24 hours a day, 7 days a week. It's like a car. You can't run it at top speed from Port of Spain to San Fernando. It will blow up. So right now we're in a good space with between, I think, 400 to 600 tests a day, and we are comfortable with that load. And if the population continues to wear masks, sanitize, stay home if you are ill, we will be in a very, very good place to turn around results. Thank you very much.
Thank you very much, Minister. And we're always grateful for the benefit of technology. The media representative from CL Communications, Ms. Singh, has submitted her question because we did have some audio issues. And her question is as follows. Given that there are trends of downward statistics, does it mean that there will be a relaxing of some of the measures in place? This is from Ms. Singh from CL Communications.
Okay, thank you, Ms. Singh. So, again, as we said this morning, the Honorable Prime Minister, after he meets with us, he announces in his best judgment, and his judgment has been sound so far, what measures will be taken at the end of this period, which comes to an end, I believe, on October the 11th. So today is the 3rd, I believe. So we just have about another 7 days to wait. But we are doing this in an effort, as I said, to save lives and livelihoods.
Thank you, Minister. And we have a follow-up question from AZP News at this time.
Yes, good morning again. Minister, the budget day is on Monday. Is there anything specifically you want, as a priority from the minister as you go forward in terms of the fight against COVID? Thank you.
Thank you, Thank you for the question. You may recall prior that earlier, when the last budget was passed in 2019, I don't think anybody knew the word COVID. So there was no budgetary approval for COVID. But when COVID hit us, you will recall I did go to Cabinet and I took a note to Cabinet for an expenditure, well, not an expenditure, for a proposal that $157 million be made available to the 4 RHAs and the Ministry of Health for their COVID response. And that was outside of a budgetary approval. Tobago, in addition, got an additional $50 million outside of the THA's piece of the budget. So I could allay all fears. The Ministry of Health's COVID response, by any mechanism, will be well funded. The preliminary figures that we ran, because we had to close off accounts, of the $157 million that Trinidad got, the 4 RHAs, I think we have spent so far $79 million of that 157. So have no fear. The country's COVID response will be financed, out of recurrent or out of special allocations, as we have done. Thank you very much.
Thank you, Minister. And we go now to a follow-up question from TTT.
Hi, good morning again. Sunil Lala from TTT News. Minister, can we get an update on the antigen testing? When is that expected? And part B of that question, I'm seeing online, there is a medical institution, I would not call the name of it, but they have about 6 locations in Trinidad and Tobago. They are offering antibody testing. I know with the PCR testing, they would have had to got approval to do so. Does that apply with the antibody testing as well?
Right. Thank you very much, Sunil. So, we have ordered through PAHO 160,000 rapid antigen test kits. The entire shipment is due for delivery by the end of October, going into November. About 2 weeks ago, I reached out to PAHO, and this is where the difficulty lies, trying to get an expedited first batch. I said I would like to have about 20,000 up front. The problem is to fly in, to hire a whole plane, because transport routes have been adversely affected due to COVID. Planes have to do what is called cargo consolidation. They are not going to fly in 20,000 kits into Trinidad alone. So we are trying to consolidate some cargo. PAHO is working with me to get an advance shipment of 20,000 kits before the estimated arrival of the whole batch of 160. But we are at the, I would say, we are constrained in how flights are coming into Trinidad and Tobago with less than economic cargo loads. So we are working with that, but PAHO has assured me that by the end of October into early November, all the kits will be here, but I am working overtime to get 20,000 kits into the country beforehand. Dr. Hines will talk about the antibody testing.
Now, I'm going to address really the scientific principles behind the antibody versus the antigen testing. Antibody testing, as you would be aware, is the test that shows whether your body has generated an immune response to an infection. As a result, it is necessarily a delayed manifestation of your infection, and an antibody test will show up as negative in the initial phases of any acute viral illness. In fact, this antibody test that we're looking at, I think, only begins to show positivity between 10 and 14 days after you have initially been infected. As such, it has its own place in the pantheon of the testing that we will do, but it is not the test that we will rely on for acute diagnosis. It is not the test that we will rely on to see whether currently ill people have COVID-19 or not. So it doesn't hold that level of priority. The test that we would use for that would be the ones that either detect the genetic material of the virus, those are the PCR tests, or some part of the virus's coating. Those are the antigen tests. So in the scale of things, the PCR and the antigen testing are where the focus is, and antibody testing will be evaluated, validated, and then brought on stream as appropriate.
Thank you very much. And CNC3, please pose your follow-up question at this time.
Hi, thank you so much. This is for Dr. Avery Hines. I just wanted to, I'm guessing this is who you were responding to when you explained that some people are misunderstanding the use of the EPI curve. I just wanted to get some clarity. So this data scientist from Ulytics, I think, is not seeing 1,200 cases. And I just wanted you to kind of explain how it is that he's misunderstanding the data and thinking that there are 1,200 persons that may be missing from the Ministry of Health reporting.
Okay, I think the first bit of your question actually answers itself. If we are aware that there are 1,200 cases that you are not seeing in one particular graphic, it means that you're aware of the cases, so they're not missing. We have a full count of all the cases that have been diagnosed. The point that we were making with the EPI curve is that we utilize another subset of data, a separate data source, to corroborate. This is what we do in epidemiology and public health. We utilize data from multiple sources to get an understanding of temporal patterns in disease occurrence. So the EPI curve, while it comes from a different data source, it corroborates, it has the same overall shape and pattern as the total number of tests that we have been reporting on a daily basis. The total number of tests had a particular challenge in the time frame when there was a backlog in the testing that gave the shape of the graph a misleading sort of contour and gave the idea that a particular point in time may have been the peak, whereas that point in time, when you look at the epidemiologic curve, was actually earlier on in the process. So when we look at the epidemiologic curve, the epidemic curve, what we're looking for with this data source is not to quantify all the cases. We've already done that. That's already been reported. The curve is then utilized to give a better understanding of when cases would be occurring, when declines would have begun to be seen. So you're not having the impression that the cases are speeding up when they're actually beginning to slow down. So the EPI curve helps you to understand when in time cases would have occurred. It helps you to understand a pattern, but it's not the tool that we're using to give the full numbers. So there are no missing cases. The cases have been reported. The EPI curve then shows you a pattern. It gives you a better idea of when that would have happened using a corroborating data source. I'm hoping that clarifies better.
Thank you very much. And today we introduce a new segment. We will respond to questions that you, members of the public, have submitted to us via telephone, email, and social media messaging. Our first question. I need a fit for work document for my job. Where can I get this?
Okay, I'll take that first question. There are two sets of pathways that people will utilize to return to work, and they come from the two circumstances under which people would have been kept at home. Individuals who were diagnosed with COVID-19 and who were isolated at home will get from their CMO's a document that says that they have now cleared that infectious period and are fit to return to work. The individuals who were in contact with them but were not diagnosed and were not ill are issued something called a quarantine form or quarantine certificate, which indicates the duration for which they are expected to remain away from work. So that's a self-limiting document. That document in and of itself indicates the date on which you become fit for work once more. So a separate fit for work document isn't actually required, but you can always liaise with the CMOH office which had issued the fit for work if you're having a difficulty, if you need to explain that to the employers in some other language. You may have assistance from your CMOH or one of the representatives to make that a little clearer.
Thank you very much, Dr. Hines. Another question that we get very often, it's about mask wearing. Should masks be worn with shields?
Okay, again, I'll take that one. Ideally, you want to have the holes in your face, the nose and mouth covered by a mask to prevent the expulsion of droplets. The legal framework that we have for face coverings allows for both masks and the shields, either or, but if you want to optimize, then yes, it would be recommended that you do wear a mask even if you're wearing a shield. But either is legally acceptable. We just want to encourage persons to the greatest extent possible to use the mask, which adds a literal extra layer of protection.
Okay, thank you. And the final question from the public this morning. Should a person self-isolate or self-quarantine only if they are instructed to do so by the Ministry of Health?
Okay, I'll take question number 3 as well. I think this is an excellent question. It gives the opportunity to point out that no, you don't only wait for an instruction to isolate. If you have symptoms, if you have any sort of respiratory or viral symptoms, we would like you to initiate your self-isolation even as you reach out to the health system for your assessment. So you don't have to wait for an instruction to tell you, don't go to work, don't go out into public places. You begin that isolation as a responsible member of the public, and as a responsible member of the public, you also reach out to ensure that you get assessed and reduce your risk of any adverse outcomes. So no, you don't wait. You do self-isolate initially, but don't self-isolate and fail to reach out. Don't forget that you also need to make sure that you are assessed. So you don't self-isolate and isolate yourself from the system, the health system. You isolate yourself from getting into contact with individuals whom you might make ill. So thank you for that question.
Okay, thank you very much. And we're coming to the end of this morning's press conference. We just want to confirm that our members of the media have no more questions today because we are ready to come to the end. And I think we've given everyone an opportunity to indicate. Everyone is very clear. Thank you very much for your participation today. And we conclude with a video from head nurse Renee Solomon, one of the dedicated healthcare workers at Cora Hospital. Be safe, everyone.
COVID-19 is here and has become everyone's business. It's not a respecter of age, race, gender, one's financial, educational status, or mental and physical ability. Therefore, it is our duty to prevent the spread of this virus in our communities. We all have a part to play with this pandemic. Therefore, there's so many things we can do. First of all, we can wear our mask, practice good hand hygiene, that is washing your hands and hand sanitizing, as well as maintaining the social distancing at least 6 feet apart. Added to that, you can eat well, rest well, hydrate well. Ensure that you maintain your immune boosters by taking multivitamins. We, the frontline healthcare workers, need you to help us with this fight. To those suffering with predisposed and health conditions like asthma, diabetes, hypertension, renal disease, autoimmune disease, just to name a few, take your medications as recommended by your health physician. Families, friends, I urge you to ensure that their supply is adequate. Do not let it finish. Also, take your recommended diet as per health condition. Do not cheat. For to cheat means you put your body in a difficulty to cope. To those persons living with depression, other health and mental health and emotional health conditions, self-quarantine is a difficult time. We know and understand this. I urge families and loved ones, do check up on them regularly. Send a voice note, make a phone call, extend your love, care and support to them as they do need your care and support at this time. To the youth of Trinidad and Tobago, do not think for 1 minute that you are exempted from this virus. I urge you to encourage good behavior amongst your peers. Do exercise good health practice, and also ensure that you exercise the preventative health measures in this pandemic implemented for your benefit. I must add, in support of my health colleagues, we are committed to ensuring that you receive the delivery of care that is necessary to aid a speedy recovery for those who end up with this virus. Do act responsibly. Ensure that you maintain good health practices. Protect yourself, and in so doing, protect your loved ones. For prevention is so much better than
As a father and a husband,